Good afternoon and welcome to Mass General Kidney Transplant webinar for clinicians. We're happy you could join us today for this important conversation. My name is Jody Jones-Turner and I'll be moderating today's meeting. This session will be recorded. I'm just going to give it a few seconds here because people are getting logged on. So I'm just going to give it a moment until we start. In the meantime, I'm going to start by introducing our speakers. Today we have with us Dr. Nahel Elias, who's the Surgical Director for the Mass General Kidney Transplant Program. Dr. Elias teaches medical students, residents, and fellows and directs a Harvard Medical School transplant surgery course. He is a member of the UNOS Living Donor Committee and speaks frequently about the transplantation research projects he leads on immunosuppression and utilization of hepatitis C and HIV organs for organ transplantation. Dr. Leo Riella is the Medical Director for the Mass General Kidney Transplant Program. Dr. Riella has an active research laboratory focused on understanding the mechanisms of immune regulation and on the development of novel therapies to promote organ tolerance. We also have Dr. Malika Mendu, who is an Assistant Medical Director for Quality and Safety at Brigham and Women's Hospital. Dr. Mendu is also a practicing nephrologist and the Associate Director of the Mass General Brigham Population Health Management Team. She received her MD and MBA degrees from the Yale School of Medicine and Yale School of Management. Thank you to all of our speakers for leading the discussion today. I think we'll go ahead and get started. Dr. Elias, I'll turn it over to you to lead us off.
Thank you, Jody, and welcome everyone to this webinar. We're glad to have you. I'll be speaking a little bit about early referral and preemptive transplant, and then we'll hand it over to Leo to continue. Next slide. The goals of this talk will be focusing on the therapy options for kidney failure patients, preemptive transplant advantages, and talk about the regional differences that we have here in New England. Next slide. As we all know, dialysis and transplantation are the main options for kidney failure patients. And dialysis could be in center or at home, hemo or peritoneal dialysis. Next slide. Transplantation provides better outcomes. As we see here from the USRDS data, the mortality rate on dialysis is the highest for the ESRD patient population and the Medicare population 65 and older, compared to acute MI, CVAs, cancer, diabetes, and all other causes. And you see in the yellow line, transplantation with much lower mortality rate. Next slide. What's also relevant is the fact that the longer the patient is on dialysis, the higher is their mortality rate. As we see here, comparing patients who are on dialysis less than 2 years, 2 to 5 years, or more than 5 years. Now, overall, these numbers are improving. As you see, the mortality rates are decreasing, but still it is significantly higher for those who are on dialysis longer. Next slide. Compare that to renal transplantation, and this is going back to 1999, where Wolf and colleagues published in the New England Journal, showing that the mortality increased with transplantation for a very short period of time, despite the big operation and the initiation of immunosuppression. As early out as 100 days, the risk were equal. And beyond that, there was significant benefit to transplantation with a lower relative risk of death compared to maintaining on dialysis. And this was comparing 23,000 kidney recipients to 46,000 patients on dialysis. As we see here, this paper showed that the long-term mortality rate were 48 to 82% lower for transplant recipients compared to those on the wait list. So these are well-selected ESRD patient population who were listed for transplant. The relative risk of death at 18 months post-transplant was a third what it is on dialysis, and which was statistically significant. Next slide. Preemptive kidney transplantation is defined as transplantation prior to initiating chronic maintenance dialysis. And it's been shown to improve patient and graft survival, improve quality of life, and reduces incidence of rejection episodes and medical costs associated with dialysis. Avoiding dialysis reduces the risk of catheter-associated infections, no requirement for permanent vascular access, and reduces the dialysis-associated cardiovascular event. There is some theoretical disadvantage, which primarily is focused on the failure to make the most of the native kidney function. So ideal timing for transplantation has not been well defined. Next slide. That said, Meyer Kreische has shown, again, going back to 2000, that the longer the patient has been on dialysis prior to transplantation, the worse their outcomes. Comparing here those who did not have dialysis to those who had dialysis anywhere between 0 or 48 months or longer. And you see that their patient survival at 8 years out is decreased by about 5 to 7%, and graft survival is decreased by about almost 20%. Next slide. The same group has also looked at longer data and looking at a larger cohort of 56,000 patients. And this is where preemptive without dialysis transplantation has shown almost 50% better outcomes at 10 years compared to those who are dialysis more than 2 years. Next slide. And over the past couple decades, this has been looked at by multiple groups. You see this meta-analysis showing 29 studies and coming out with a recommendation for preemptive transplantation with living donor and recommending it highly. Next slide. And these recommendations have also translated into the major societies and the outcome initiatives like KDIGO, as well as the European, the British, and the Australian, New Zealand societies, all advocating for kidney transplantation without dialysis. Next slide. And as I mentioned earlier, living donors are the best way to provide that, but they're also expanding deceased donor options with multiple types of donors that we have used and got excellent outcomes with this option, and we encourage that. Next slide. Unfortunately, across the country, going back to 2003, only 2% of 2% of patients initiating ESRD care had transplant as their first therapeutic option. That increased to 2.4% in 2015 and to 3% in 2017. And one thing we can talk about, which is the advantage that we have here in New England, where our rates are higher than the national rates. Comparing to 2015 rates, we had a 4% compared to some lower states, lower rates in certain states like Alabama, Mississippi, and Tennessee. Next slide. This study also looked at who are the patients who are being referred and listed early for transplant, and they noted that those who had significant burden of kidney disease and those who had good physical activity. So you got the two extremes, but probably the patients in the middle are those who benefit as well, and this is where we encourage everybody to be listed for transplant therapy. Next slide. And one big piece about it that changed a few years ago with the new kidney allocation system implemented in December 2014, which the idea of it was to make better available kidneys utilization, improve opportunities for difficult to match patients, and increase fairness. And that was implemented in December 2014, as I mentioned. Next slide. Friedenwald was the chair of the committee at the time, and he presented this at the AST webinar. And one thing he emphasized, the fact that the new policy at the time for 2014 advocated for awarding waiting time points for dialysis time pre-listing, and that's to be more fair. But one thing about waiting time for patients who are not on dialysis, they had the right to be listed once their GFR hit 20, and in addition to that, they would start gaining waiting time at that point. Next slide. And that is very significant for us here in New England. As you see, the UNOS divides the country into 11 regions, and we're region 1 here in New England. Next slide. And there are about 52 donor service area. But as you see, New England pretty much is, most of the region is one donor service area. There's a small second donor service area around Hartford and Springfield, Massachusetts. And lucky for us, next slide, we had a different assignment for waiting time, where time on dialysis only was what counted prior to CAS, which was not ideal for the patients because all their waiting time pre-dialysis wasn't counted. Now, once CAS was implemented in December 2014, it became unified one way across the country. And this is where it essentially eliminated that problem for our patients as long as they got waitlisted early and referred early. Next slide. A couple other points about CAS. It added points to CPRA, where the calculated pan-reactivity antibody with patients having been sensitized, they get more points. And you see the old system used to give 4 points for patients who are more than 80% sensitized. But what changed is into a logarithmic scale, as you see here, which grants up to 17 points for a PRA of 98%, and actually it goes much higher than that for 99 and 100%. In addition, it grants DR mismatch points, 0, 1, or 2 points, when there is a DR that is similar between the donor and the recipient. Next slide. This is a summary of how many points patients get, as you see here, and 100% sensitized patient gets 200 points, but more importantly, they get national priority in the allocation. Next slide. Another piece that was added at the time was the expected post-transplant survival, or estimated post-transplant survival, where patients were stratified by a percentile, and the younger, the healthier is the patient, the less time they are on dialysis, and the less likelihood of having a prior transplant will grant them essentially estimated post-transplant survival to be higher, with the idea that kidneys that are likely to survive longer would be offered to those patients, so they will benefit more from it. Next slide. So for that reason, the KDPI was calculated, which looks at factors within the donor to identify what would make this kidney last less long-term. And this is where the best quality kidneys were preferentially offered to the best quality recipient. Next slide. So what we see in here is the 4 sequences of allocation that we go by currently since 2014. The best quality kidneys with the KDPI 0 to 20, as you see highlighted in yellow, has a higher allocation for those who are top 20% in estimated post-transplant survival and the pediatrics patient. And the allocation goes, as I mentioned earlier, the highly sensitized get some advantage, the 0 mismatch, prior living donor get advantages, and then local, regional, and national. Sequence B, these are KDPI 20 to 35, and this is where the pediatric population gets advantage. Sequence C is essentially the majority of the kidneys with a 35 to 85 KDPI. And finally, sequence D, which is the worst 15% of kidneys with a KDPI of 85% or higher, where they get allocated differently. UNOS requires that we have a special consent from the patient agreeing to these kidneys. Next slide. So at the end of the day, looking at CAS and the preemptive transplant, there are multiple options that have provided the patients, number one, those who have slow progressing renal disease, they would benefit preemptive transplantation. They should be listed early, and they're accumulating waiting time while on the list. And while issues in their care could be managed, could be adjusted, we can identify these and resolve the issues. As I tell every patient, we're here to help you get to transplant, not to tell you you're a candidate or not. We want to make everybody a candidate. Sensitized patients get advantages as long as they're referred early. Zero mismatches in the ABDR on the HLA get advantages, and everybody accrue waiting time with a GFR less than 20. And that's the idea of helping patients by preemptively listing them. I'll stop here and I'll talk a little bit later about the new allocation coming in December.
Thank you, Nahel. Good afternoon, everyone. My name is Leo Rial. I'm the medical director of the kidney transplant program. I know it's a lot of information in terms of trying to understand how the allocation works, but I'll give you the approach that we have optimized Mass General to streamline this evaluation process and give the best chance for our patients to be able to be transplanted with the shorter amount of time possible on dialysis, and ideally without being on dialysis. Next, Jody. So next, just click twice. So the timing of referral, it's really important, and I think we would like to get our patients listed as soon as they have a GFR hitting 20, and of course, this is important that we start planning even ahead so that they can come get some of the initial testing done. So in general, we use the GFR of 25 or below as being a good cutoff of thinking of sending this patient to be seen by our transplant evaluation team. And next. And I think what's important is that we want to try to be planning things ahead, at least a year ahead, to get a living donor, to get through the process. It can take months. So we got to be ahead of the game when we're talking about referral. Next. So overall, if we look at our past 2 years, we've been successful by getting patients referred before they get to dialysis. So 65% of our referrals since 2019, so that's 1,595 patients, they were seen by us while they were still not on dialysis. I think we can still improve that number, but this gives you a sense of how important it is for this early referral and how we can start accumulating time, as Nahel showed to you, that now the allocation policy allows these pre-dialysis patients to be accumulating time once they have one GFR at 20 or below. Next. So how do you refer patients to our transplant program? So if you're inside our system, the Mass General Brigham, you can definitely put a referral order through Epic by just typing MGH transplant. There's also websites that you can do from wherever you are, and I'll show you a little bit about that. And there's more of the traditional ways of sending by mail, a phone call, or even a fax. Next. So if we think about the kidney transplant referral, if you just type on Google kidney transplant referral MGH, the first hit is refer a patient to the kidney transplant program. And click that, please. And that opens up, next, yep. And then that opens up this refer a patient website, and it has some minimum information that's required for that initial referral. And then on our end, we receive this referral, next, and we start the process. And this process, just to highlight and make it very transparent how it works, once we get the referral, within 48 hours, the patient is called in order to answer some specific questions, and also if they're not registered at Mass General, to get their medical record number registered. The second step is to get their financial clearance. And this is really important because we're thinking about not only the pre-transplant, but also post-transplant, figuring out exactly what is the insurance this patient has and what other insurance that he may need, or she, in order to be protected and not suffer any of the financial burden of the transplant. And we have a dedicated team in our transplant group that basically goes in and knows all the nuances about the different insurance plans and tells, black and white to the patient if there are any problems or anything to expect as financial burdens going forward. And finally, once they pass through that financial screening, then they go through, retrieving all the records from their treating providers so we can have all that information. For pre-dialysis patients, so the exact patients that we need to list very early so they can accumulate time, we have a turnaround time of getting them scheduled to see our team within 2 weeks. So that's now with the COVID, some of these patients that are low complexity, we can even do virtually. For some of the more complex patients, we ask them to come in. But this is really important so we can maximize the time that they are on the waiting list and therefore their chances of getting a transplant even before they get to dialysis. Next. Jody will get into a little more details about our team, but the team is divided into geographical regions, and I'll defer to Jody at the end. We have Amanda, who leads our efforts in terms of making sure the communications is going across both the referring providers and our team. And but Jody will get into more details about the individual nurse coordinators that we have. Next. So the biggest question that we have is when a referring provider calls us and say, okay, what happened to the appointment of my patient and why he has not been seen by transplant? And sometimes there are a few things that happen along the way. One is insurance. If there's a problems with insurance that we would like the patient to work on before we move forward with the transplant. Of course, communication issues is always an issue that it's important for us to know and that we try to improve as much as we can. There's some medical conditions that are contraindications for transplant. So if the patient has a low ejection fraction below 30%, metastatic cancer, severe deconditioning, active drug abuse, these are cases as the BMI of above 45, where the patient would be, told that they have to work on those variables in order to be considered a transplant candidate. And of course, sometimes the patient does not want to think that ahead and does not want to see us. And I think this is important as well for us to recognize that it's definitely something that also occurs with some of the patients that don't come to our referral, even though we have them scheduled. Next. So what is the criteria that we use for that initial listing? So the patient has to attend or view one of our educational presentations. He meets them with several of our Mass General transplant team, either in person or virtually now through Zoom. They have to have a GFR of 20 or less or being on dialysis, an expected life expectancy of at least 3 years, have a good social and emotional support to kind of support them through the transplant process, in particular after surgery, have the adequate insurance so there's no major financial burden, and perform some initial lab tests. And of course, there will be patients where the referring provider, the nurse, the physician may think that the patient may not be a candidate or is an offense. And these are the patients that we definitely encourage you to send to us. We can assess and have a better idea on our end as well if we think the risk benefit would favor them moving forward with transplant, and then we'll circle back to you to get your feedback as well. And this is really an important and a part of what we do here is that communication piece and trying to get the most patients we can as long as it's safe and as long as we feel the benefit is greater than the risk. Next. And when after that initial visit, there's usually a committee where some of the patients where the eligibility for transplantation is uncertain that we discuss along. So it's a multidisciplinary selection committee. And in this committee, we present some of these more complex patients so that we can get input from everyone in order to decide if the risk benefit favors transplant or not. And then once we have that meeting within 1 or 2 weeks of that initial visit is when we get a final kind of decision. Next. One really important process, as Nahel was pointing out, is that many of our patients, unfortunately, may not have in their mind at least a living donor that could potentially donate so they can transplant before going to dialysis. So we have come up with 2 strategies to facilitate the reach out into the living donors. One is a very easy survey that can be completed online, mjlivingdonors.org. And this can be sent to potential donors. They can initiate that survey. And that's a really kind of a screening test where, if there are any red flags that would not make them a candidate, you get a message saying, thank you so much for your generous offer. Unfortunately, you're overweight and you should lose at least, say, 69 pounds before you're considered for transplant. So this expedites and makes things much easier. We also have a really important asset in our transplant program, which is Elizabeth Gigliotti. So she's a nurse, specifically focused on the living donation. And what she does is after the patient sees our team in the transplant evaluation side, she calls the patient and talks about living donation, specifically about tips and strategies in order to reach out to their community, to their family, their friends, their co-workers, to maximize their chance of potentially getting a living donor. And this is really, really important because I think it makes a huge difference when a patient walks in and has no directions of how to reach out to some of these potential donors. Next. And of course, some of our patients won't have that living donor even after the search, and they will have to wait on the list. And the list is quite long. And what we have created is a sequence that as they approach higher on the list, this is when they're going to get more frequent blood testing so we can do the cross match to make sure the kidneys are compatible. And we also would like to be in the loop in terms of what's going on with the patient. So changes in any of their health conditions we want to know about. And of course, we want to make sure they maintain their insurance, stay healthy and active, and of course have all the support system also around in terms of friends and families to provide during the post-transplant care. Next. And this is just an outline just for you to visualize all the phases that happen once the patient is listed. So there's the evaluation, the listing, and then there's a long waiting period that really depends on the blood group and of course the region that we are at. But these are the waiting time for a kidney transplant in the different blood groups. So the hardest one is the O, it takes 5 to 7 years, and the AB is the quickest, it takes about 2 years. So as the patient progresses on this timeline, this is when they get to the readiness phase, is when we update all their testing that are required, including cancer screening, sometimes specific cardiac testing, and get them ready. And this occurs about a year before we believe that they will be receiving that transplant. So this is a way of us of trying to get them listed very quickly and that not do tests that are going to have to be repeated every year, but really wait until they're higher on the list to kind of trigger that. Next. Great. Now Hal will jump in.
So I just have a couple more slides about the way the allocation is changing. Next. So one thing going back to 2000, the Department of Health and Human Services passed the final rule on deceased donor organ allocation. And a few things were emphasized. Number one, sound medical judgment to be the basis of all allocation, seeking to achieve best use of donated organs, and designing it to avoid wasting and to avoid futile transplants and promoting patient access to transplantation. But one of the items was brought up was that allocation should not be based on the candidate's place of residence or place of listing, except for the extent required by the above. So if sound medical judgment makes more sense to keep an organ within certain boundary, then we should do that. But otherwise, the allocation should not go by that. Next. Now, the one slide I showed you earlier in the sequences of allocation that we've been going by since December 2014, and I highlighted here the local and the regional allocation. So going back to the map that I showed you where the regions and the local area, which is what we call the organ procurement organization donor service area, so that's what drives the allocation as you see across the board. So that is changing. It's proposed, the proposal has been approved, and currently UNOS is in the process of the computer programming for all this to take effect. And all this local and regional will be disappearing. Next. So the new allocation of 2020, which we expected to go into effect in December, will replace the local and regional allocation, combine them together into a 250 nautical mile distance. And that's a straight line distance between the donor hospital and the recipient listing hospital. Essentially, instead of that will take over local, region is eliminated, and the national allocation will remain, but will be changed to 2,500 nautical mile, which covers a good percentage of the country. The other piece that's being factored in is a kidney allocation score, which, as I mentioned earlier, factors in the waiting time. And as we talked, waiting time is either the day, starts either the day the patient initiated dialysis or the day they got on the list, if they got on the list pre-dialysis, and they can do that with a GFR of 20 or less. And one-time GFR of 20 or less will qualify the patient to be listed. And all that is, as we tell the patients, is money in the bank. You gain waiting time added to the list. Whereas if you did not get referred, you would not get the waiting time. Now, patients who are on dialysis will get the waiting time automated to the day they initiated dialysis. We discussed the CPRA and DR matching points. The new thing that's being added are distance points. So within the 250 nautical mile allocation, we're adding 2 points for 0 miles and 0 points for 250 nautical mile. And in between, it's a linear. So at 125 nautical mile, it's 1 point. And I'll show a map and explain that in a second. Beyond 250 nautical mile, at 250 nautical mile or 251 nautical mile, really, the patient gets 4 points and 0 points at 2,500 nautical mile, and again, linear in between. Next slide. So the allocation algorithm is going to be like this. The highly sensitized will get the, again, advantage. The 0 ABDR mismatch on the HLA type between the donor and recipient will get advantage, primarily to the top 20% EPTS. Then it goes to living donors. And then the local is now changing to 250 nautical mile for pediatrics, for top 20% EPTS, then all 0 mismatches, and then all within the 250 nautical mile. But again, within each category, the patients are on the list based on their score. And in addition to their sensitization and their waiting time, now we have distance, which will be different for each donor organ because depending on where the donor organ is. And again, as you see across the board, the 250 nautical mile take over the local, and the regional, which usually comes right after local, will be disappearing off the list. Next slide. This is a map of the Northeast region, and in a red dot is Mass General, and in blue dots are every donor hospital within 250 nautical mile, where our patient will have access to kidneys donated in any of these donor hospitals. Now, if we look at the New England region, this is not new for us. We currently get organs from the New England region. What's different is, number one, the Hartford and Springfield, Massachusetts corridor, where many organs are currently allocated locally within that corridor to the Hartford and Springfield programs, now will be shared across. More importantly, we're going to gain access to organs all the way, as you see, in upstate New York, in New York City, in New Jersey, and all the way down to the Philadelphia region. All these are within our 250 nautical mile distance. Now, what's the big difference is our patients will get 2 extra points for the donor organ if the donor is at MGH. That's a 0 distance point. They will get roughly about 0 points for the Philly. As you see, Philly is on the border of the 250 nautical mile. And in between, they will get in between. Now, similar to us, every regional program, so for example, the New York programs are likely to gain access to our organs. But again, our organs, our patients will get 2 points. The New York patients will probably get just under 1 point. As you see, the distance is a little more than 125 nautical mile. At the end of the day, this will, I believe, gain more access to our patients. We've done a similar program with liver recently, and it has helped our patients, and we're hoping that this will improve the allocation across the country. So I'll stop here, and we'll pass it on to Dr. Madhu, and we'll be taking some questions at the end.
Hi, everyone. Good afternoon. Thanks for having me. So today I'm going to be discussing the Advancing American Kidney Health Initiative and what it means for you. Next slide, please. Disclosures: I provide consulting services to Bayer. Next slide, please. So the Advancing American Kidney Health Initiative was signed by President Trump as an executive order in July 2019. And it's been heralded as a major step forward in federal kidney policy. And this is by the American Society of Nephrology, other nephrology society groups, patient advocacy groups. And I'm going to detail some of the key components of the Advancing American Kidney Health Initiative for all of you to be aware of and how it specifically affects transplantation. Next slide. So today, these are the things we're going to discuss. Yeah. So first, a bit about the history of kidney health policy. So the next couple of slides will share some historical moments in terms of federal health policy related to kidney disease. So in 1943, the first artificial kidney was developed. In 1947, the technology was first used in the United States, and you can see this article in Life magazine at that time and what the artificial kidney looked at. In the 40s and 50s, there were efforts here in the Boston hospitals to develop this kidney replacement technology. And in 1954 was when the first kidney transplant was performed. And you can see the picture of the two brothers, the twin brothers, in the bottom right there. Next slide. In terms of dialysis, outpatient hemodialysis and peritoneal dialysis really started in the late 50s and then developed further in the 60s as home hemodialysis actually emerged as a major therapy. And you can see some pictures in the top right, for example, a home hemodialysis patient and the big bulky machine that was used at the time. Next slide. And this is another image from Life magazine. This was back in 1962, and there was a subsequent documentary by NBC News in 1965, which basically highlighted this panel, this Who Shall Live panel, which had 6 individuals in the community who basically decided who would receive dialysis treatment. And so that was the state of care before the next slide, before the federal government got involved, and specifically the House and Ways Committee held a hearing where this very famous patient, Chef Glazer, presented his story. And you can see here the story, which was a 40-something-year-old gentleman with 2 children who was an active member of society, working, and then needed to start dialysis, and then talked about his financial struggles with dialysis. And that testimony, coupled with congressional and executive action, led to President Nixon in 1972 signing legislation ensuring Medicare coverage for ESRD patients. And so starting in 1973 is where the end-stage renal disease Medicare benefit started. And it essentially guaranteed coverage for patients who needed dialysis or a transplant. Next slide. So that brings us to the Advancing American Kidney Health, because believe it or not much has happened in federal kidney health policy since the 1970s. There have been some incremental proposals and changes, but largely this has been an area that's been ignored at a national level. So the Advancing American Kidney Health Initiative, next slide, has, in terms of the rationale behind it and why this is so timely, many on this call will know these facts. We know that there are poor outcomes for patients who are on dialysis over time, that dialysis is largely not patient-centered, and that we have low rates of home dialysis. We also know that there are few therapies to treat and prevent kidney disease. And as was discussed, we know that the wait list for transplant is long, and that we have thousands of patients who are waiting. And finally, kidney care is costly at a patient level, at a federal level, at a society level. So next slide. There are 3 major goals of the Advancing American Kidney Health Initiative. I'm going to detail them here. So the first goal is to reduce the development of end-stage kidney disease by 25% by 2030. And this is achieved largely by supporting ongoing efforts by the CDC around surveillance, supporting ongoing federally funded research, national diabetes programs, artificial intelligence, and disease management programs. So no new programs have been proposed related to reducing the development of end-stage kidney disease, but largely supporting existing efforts. So the next slide outlines goal 2. And goal 2 is really at the crux of this Advancing American Kidney Health Initiative. It is this goal of 80% of new end-stage kidney disease patients receiving home dialysis in the home or with a transplant. And the way that this is supported is, again, supporting ongoing efforts from the existing national USRDS database to CDC efforts, to things like the KidneyX initiative, which is a public-private partnership to streamline innovative therapies. But the core of this goal is around these new value-based kidney disease payment models. And these payment models seek to align the provider incentives with patient preferences and to improve quality of life. And essentially what this means is we know that home dialysis, we know that transplant are areas of care within kidney disease that are patient-centered, associated with better quality of life. And we want to make sure that the system is aligned to support that and to encourage that type of care. So the next slide, goal 3. So goal 3, directly related to this session here, is to double the number of kidneys available for transplant by 2030. And you can see here some of the strategies. So the first is around working with the organ procurement organizations, thinking about how they're measured to increase the rate of organ recovery, to make sure we have more organs that are recovered so that we have more potential kidneys that are available. The second is an expansion of the use of hepatitis C positive organs, and there's been a lot of work done in that realm around the ability to use these organs safely. And the third is to support living donors by expanding things like reimbursement of travel, allowing people to take time for medical leave if needed. So those are some of the strategies. And again, the overall goal is to increase the availability of organs and to help support transplantation. Next slide. So how does Advancing American Kidney Health actually impact the care that's delivered in the health system? The next slide. So there's a lot on the slide, and you can see the graphic here basically outlines these payment models. At a very high level, the change here is that there are changes to the payments made to nephrologists and dialysis units through new payment models. The first is a mandatory payment model called end-stage renal disease treatment choices, and that's what's highlighted in the top part of the graphic. It's a randomized model where there's randomization based on hospital referral regions for dialysis units and the providers who care for patients at those dialysis units to basically be incentivized to facilitate home dialysis and transplantation. Now, this randomization has already been announced. The hospital referral region that encompasses Mass General and the hospitals in this Eastern Massachusetts hospital referral region, we are not randomized to this mandatory end-stage renal disease treatment choices. Interestingly, the middle part of Massachusetts, the Worcester region, is randomized. So something that is interesting, that this is going on in the state, but not affecting our particular area of Massachusetts. The second type of payment model is this optional kidney care first or kidney care contracting. There are a couple of different versions. These both essentially incentivize the same type of care. Again, there are bonuses that are given to the nephrologist for patients who are successfully transplanted. And the idea here is it is encouragement, it is acknowledging the work and the support needed to facilitate successful transplants. There's also an upfront payment that is given to the nephrologist around managing patients with more advanced CKD, again, acknowledging that these are more complex patients that need more services and coordination of care. The comprehensive kidney care contracting is the nephrologist working with a kidney care organization versus the Kidney Care First, which is a nephrologist-only model. But they all essentially incentivize the same type of care, which is coordinated care that's focused on home dialysis, on transplantation. Next slide. And this gets into some more detail about the mandatory model, as I discussed, and that 50% of the nephrologists, and actually this change, this is now randomization of 30% of the country's nephrologists and dialysis units. Next slide. I think goes into more detail about the optional model. So I've reviewed this, and so I think we can go to the next slide. So what changes for you as a patient, as a patient advocate, as a provider? We can go to the next slide. So what we should be seeing as a result of the Advancing American Kidney Health Initiative, the models that are encompassed in this initiative, is that there should be more education of patients before they start dialysis. There will now be more of an incentive to make sure this education happens, and particularly guidance around home dialysis and transplant and the importance of these modalities. Next slide. There will also be more patients on home dialysis and support for patients on home dialysis. Education is a key part of that, but also training, in some cases, making sure that their coordination support available for patients. And so that will definitely be expanded regardless of whether a practice participates in the Kidney Care First model or not, because of this mandatory model and because many practices will be participating in this Kidney Care First model. Next slide. And finally, hopefully, if all of the steps outlined in the Advancing American Kidney Health Initiative are implemented, and there's work that's ongoing around the measurements, for example, of these organ procurement organizations, and some of the other key elements I outlined, there should be more living donor and deceased organ transplants so that we can have more transplantation for our patients. I think that's the last slide. And finally, more attention about kidney disease at the national level. And I would say this is definitely a huge win with the Advancing American Kidney Health Initiative, is that there's been a lot more attention now paid to kidney health nationally, definitely by members, congressional members, and of course, executive members about kidney disease and the importance of this condition. I think that's our last slide. And just wanted to say thank you to these various groups. I'm a member of the American Society of Nephrology Quality Committee. I'm a nephrologist at Brigham and Women's and part of the Department of Quality and Safety and Population Health. And finally, all the patients who inspire this work.
Thank you, Dr. Mandu. That was fantastic. We'll probably have some questions on that because I know it's complex, all these payments and how can the nephrologists actually position themselves on it. But we'll finalize just with maybe 2 more minutes. So our idea was also to think about how can we align the nephrologists with the transplant centers. And next, and going along with what Dr. Mandu was mentioning and also Dr. Elias. So in order to improve communication so that the provider, the dialysis center knows what's going on with their patient once they get referred, we started sending these MD quarterly statements. So these are statements that the dialysis center as well as the nephrologist will receive with a list of all their patients, the phase they are in the process of the transplant referral, status, if for any reason they were ineligible or removed, and all the time points of that. So I think this makes much easier in terms of the communication. And also we have on the top the list of the top nurse coordinators, our stellar team that keeps track and helps move these patients along the evaluation process. Next. The second part is the education. Just click once more, Jody. The education, as Dr. Mandu was mentioning, is really a crucial component. And now with all the COVID and so forth, the in-person education that we used to do, it becomes much harder to get all the people around. So we created very short videos, but covering all the topics that are really important for our pre-transplant education for patients. And we're going to be having those online, and we're actually working on the translation. So we have also a Spanish version. And the idea here was, instead of having like a 1 hour long one video, to have short videos they can watch and basically cover the whole curriculum of all those educational components. They can rewatch some of these shorter ones, knowing the attention span of us and also of our patients is also something important for us to take into consideration. Next. And then finally, what we have learned from COVID, and we knew some of that in transplant already, is that there is a huge disparity in terms of referrals of minorities. And I think here we're showing in the U.S. how whites kind of dominate number of transplants, even though we know that African Americans and Hispanics have a much higher rate of end-stage kidney disease. So we are putting together and launching a Hispanic kidney transplant program in Mass General that will have dedicated physicians, nurses, and social workers that they speak Spanish. And I think the idea here is actually mirror some other successful programs that have been developed in Chicago as well as in New York of developing a culturally conscious transplant program, the one that takes into account some of the differences between patients and then help them kind of move along the way. The clear example sometimes with Hispanics is that they need a little help to get them through the process, to reach out to donors. And how can we do that extra step so they can equally compete with the whites in terms of the rates of transplant? And I think we are very successful at having partnerships with other transplant programs, and we'll be sharing specific information brochures for you to share with your Hispanic patients so that we can get them transplanted and increase the transplant rate. And then Jody, I think we'll talk next about our stellar team.
Great, thanks, Dr. Riella. We just wanted to finish here with our an invitation to you and your team members. We are, to piggyback off of what Dr. Mandu was sharing about the Advancing American Kidney Health Initiative, we're tailoring a lot of our work over these next few months to increasing access and communication and relationships with our transplant team. So as a follow-up to today's webinar, we will be hosting a Meet Your Transplant Nurse Coordinator. As Dr. Riella mentioned at the beginning of the presentation, Mass General's approach is a little bit different than other centers. Our nurse coordinators are organized by geography. So they each cover a region, and we have maps here that detail which region they cover: Molly, Laura, Michelle, and Linda. And then we just welcomed a new nurse coordinator, Jamil Suleimana. So each of the nurse coordinators will be hosting a Meet Your Transplant Nurse Coordinator session intended for people who work in their regions. So if you work at a dialysis center or a nephrology office in the South region, you would want to attend Molly's webinar. If you work in New Hampshire or an out-of-state region, you would want to attend Linda's. So we're organizing these by nurse coordinators so that we can offer time, individual time with the team, and offer an opportunity for relationship development. So with that, that's our final slide. I will open it up if there's any questions in the audience. We have just a few minutes left, and I'm sure our speakers would be happy to answer any questions that have come up with any of our attendees from today. You can use the Q&A or the chat.
Dr. Mandu, may I start before we get any question about some of these compensations, financial compensations that the Health Kidney Initiative have proposed in order to also encourage the providers to refer for transplant?
Yeah. So I think, The key incentive is around the kidney transplant bonus, which is part of the Kidney Care First model. Now, this is an optional model, so it's really for those practices who choose to participate. And some will choose to participate starting in April, and some may choose to participate starting not this January, but the following January. And the idea is that for patients who are stage 4 and 5, when they are referred for transplant, when they get successfully transplanted, they will receive, and we're waiting to hear the final details on how much will be the kidney transplant bonus. But the initial guidance was it would be around $15,000 per patient who successfully transplanted, and that would be paid out over 3 years as long as the transplant is successful. So the goal is really, to acknowledge that it is, a fair amount of, coordination and attention and education to ensure that patients are appropriately transplanted, to recognize that, and to incentivize and hopefully improve transplant referral rates.
Thank you.
So it looks like we were so comprehensive in our presentation, we don't have any additional questions coming through the chat at this time. So is there anything else that any of our speakers would like to add before we close?
The only thing I'd add is, as I mentioned, the Worcester area hospital referral region was randomized in the mandatory model. So what that means is all of the units and all of the nephrologists who practice in that area, they are going to have this incentivization because they are going to be, so they didn't opt in to participate, they are just participating. They're going to have this incentivization to increase their transplant rates. And so that's just something for folks to be aware of because this is happening in our state. And it's, I think requires a lot of thought to think about how that might impact, transplant programs, whether there should be, outreach to providers and units in that area to think about that. Because I would expect that there would be an increase in referral rates from those units and providers.
That's great. And then we had someone, we had a hand raised. So user Freeman, you should be unmuted. So if you want to ask your question, or you can type it in the chat. Okay, we'll see if it comes through in the chat. And then we have a question in the chat. Can someone explain more about how your the telephone referral process works? I'm happy to take that one. So I think that the question is around if someone calls in, we do have a main phone line that's answered by our PSCs, and we would be happy to take phone calls if it's easiest for you to call in. We would ask that after you make that initial phone call and have any communication with our team, that there would be information that we would need to have faxed into us so we can some supporting documentation.
Yeah, I think there's a follow-up question about how to avoid barriers with required documentation and paperwork from Justine Gleesman. And I think so we're coming up with strategies of pre-populated forms and other potential approaches so that you as a provider, as a nurse or physician, who have the least effort in order to just send us the referral. We know that these online forms sometimes are helpful, but if there are other ways that we may facilitate to get your patient referred to us, I would love to hear about and work with you. I think this is definitely something that we want to remove the barriers and make it as simple as possible. I think the COVID has brought some positivity, I think, to this aspect of what we do in transplant, especially with the virtual visits and other things where patient doesn't have to come in sometimes for an appointment. And even we can fit more patients to be seen. But I think that initial process still is something that we would love to get more feedback and continue to improve. And Jody is our leader in trying to optimize all of that. So I'll defer.
I'll mention one additional thing in addition to the education videos that we've been working on. We also see that there's a real need to have a handoff communication between nephrology offices and the transplant center, something that can start the conversation with patients. So we're also working on a PDF that we can share easily with you that you could then either email or add to an after visit summary once you see patients and want it to refer them over to Talk to Transplant. I do see one more question about the allocation process is confusing. Can you direct me to some place that they can read more? Dr. Elias, do you want to take that one real quick about where people could read more about the allocation?
I want to know that place as well, Nahel, because it gets more and more confusing with this, all these different criterias and so forth.
Yeah, no, absolutely. I mean, and there are obviously these allocation parameters are taking quite a bit of time to develop and to factor in all these pieces. So the OPTN website, which I put in the chat, optn.transplant.hrsa.gov, is where it's all explained. And at the end of the day, you know, I mean, the allocation is necessary to understand for us who are seeing the allocation and seeing how is it affecting our patients. And as I mentioned, it takes a few months and sometimes longer to figure out how is this going to be different for us. As I said, we've experienced the same thing as far as the allocation by distance previously with livers and with hearts and lungs as well. So we have an idea, and we're working with other teams to capture them a little bit better. At the end of the day, the biggest point to focus on the patient is the earlier they're listed, the more waiting time they have. And that's the one thing you can control. You know, nobody can control their CPRA. Nobody can control where the donor is. The closer is the donor, there is more advantage for the patient. That's true, but nobody can control where the donor will happen, that they will get a kidney from. The one thing we have control over is, at the end of the day, when the patient was referred and when were they listed. And this is what it takes an effort on both sides. And this is, you know, going back to Leo's point, we want to work with you as a referring provider. So if you refer early, we want to get the patient on the list quickly. And that's where the patient starts gaining waiting time. And that new model that we have that Leo showed with the readiness, where we get the patient on the list and we do the evaluation later, the patient is gaining waiting time. And as I said, it's money in the bank. There's no harm in getting that waiting time added. And that's the one thing we have control.
Yeah, I second that. I think the timing that the patient is on the list is what, you know, it's the only thing that we are able to control in terms of getting them higher on that line. And I think this is where I think most of our focus should be in that early referral. Thanks, Nahel.
Great. Well, that's a great note to end on, and we're a little bit over time. So I'm going to wrap up here and say thank you to everyone who attended today. We did record the session and we'll share it afterwards if you have colleagues that might be interested in the content as well. We appreciate your time. And thanks to Dr. Elias, Dr. Mendu, and Dr. Riella for your time as well. Bye-bye.
Thank you, Jody.